Welcome to SNF This, the podcast where we pull back the bed sheets on skilled nursing facilities, educating, entertaining, and occasionally risking being reported to HR.
Awesome. Welcome to this episode of SNF This. Really excited to have Dr. Gonzalez on today. I've learned a lot from her already in our short time knowing you in the last year, and we've been working together and love working with you and your facilities. And so excited to have you on today. Thanks for braving it and being here today with us.
Yes.
So Dr. Gonzalez, kind of tell us your background, your training and education, and then what got you into long-term care, specifically the SNF side. And my favorite question is what keeps you in this space? Why do you keep doing what you're doing?
Okay. So let's start from the beginning.
Yeah.
I'm one of those few people that when they were in high school, they knew what they wanted to do.
Okay.
And I started my life to a program that I was supposed to do 2 years of college and then go to medical school.
Okay.
And then when I went to college, I said, I want to stay another year. And that's how I went to medical school.
Okay.
Medical school, I had a great mentor that used to do family practice, and that's how it took me to family practice.
Okay.
Then I did different kinds of medicine. I did underserved, then I did private practice, and then that was child number 3. And then I was on the lookout for something that was more family friendly and flexible.
Okay.
And somebody knocked at our door and said, we need a doctor to work in the nursing home to help another doctor, that her profile of patients was very large. And I remember that first month I had maybe 30 patients, and it kept doubling. And I started with 1 nursing home, then I had 4 nursing homes. And I really enjoyed it because I could see the patients. And I did my family practice residency in ECU.
Okay.
And they have a really strong geriatrics program.
Yeah.
So I felt that as soon as I started working in the nursing home, I knew what I was doing. And I don't know, there's something special about old people. And then I have all this flexibility. I could see my patients, then go to the school, volunteer. I had my baby, my 3rd child, and it just worked. And then I think I had been doing the job maybe for a year and a half. And then my other half said, oh, you're enjoying your job so much that I want to do that too.
Who's a doctor as well.
Yeah.
We'll have on a later episode.
Right. So, and then that was 21 years ago. And I don't miss private practice. It's very challenging. You have to be a very hands-on clinician, and your patients are very complicated. So I just love it.
That's awesome.
Yeah.
And you're great at it.
Thank you.
Your patients and your facilities love you. You're also a big runner, aren't you?
I am.
What's your training schedule, and are you training for any races right now?
But wake up at 4:30 in the morning, and the exercise gets done. So probably run, it depends, maybe 4 or 5 days a week, and then 1 day of biking. I just did a 55K in the mountains.
Holy moly.
It was called the Mount Mitchell Heartbreaker.
Congrats.
So, thank you.
Yeah.
So that's the training that I did. Now I've completed a 55K. Now I'm ready to be a grandma.
Okay.
And that's
You're gonna be a grandma?
I am. It's gonna be in 2 weeks, probably, or maybe 1 week. I don't know.
Boy or
we'll
girl?
see. It's a girl.
Girl.
Her name is Carolina.
That's exciting. You'll be a great.
I know. I'm excited. So
Too
now
young
I'm gonna
to
be a grandma.
but you'll be great.
Yeah, I'm gonna be a bad grandma. Yeah.
You'll be awesome.
Yeah.
You'll be so good.
Yeah.
One of the things I wanted to kind of pick your brain about, and a tough topic, especially for an acute setting, but also for your general rounding providers, is optimal pain control. And what does that mean? Pain can be subjective versus we can reach for some things that we know would take care of the pain right away, but cause problems later down the line. So what's kind of your approach to prescribing pain medication or treating medication, or what are kind of the steps and process you go through, evaluating pain management and control?
That's a big topic because I know, because you could have musculoskeletal pain, then you could have abdominal pain.
Fair.
And what I would say about abdominal pain is that before giving any type of pain medication, we have to figure out why. Because the pain could be that the patient hasn't had a bowel movement in more than a week.
Right.
So that's a different kind of pain. If we talk about musculoskeletal pain, I guess cancer, post-surgical, which is, I think, a lot of the phone calls that the providers are going to have.
Yeah.
I always start, there's nothing wrong with Tylenol.
Yeah.
unless you are allergic to Tylenol, which we have patients that are.
Yeah.
If you have liver disease, but if not, that will be my place to go to start with. Probably when you guys are on call, the patients are already in Tylenol.
Sometimes, but not always. But I think it is one of the things that providers forget to check is like, are they on some of the simple things like Tylenol?
Yeah, I will say I will always start. And then the other thing is with our population, younger people, we probably will go to an NSAID, and it could be ibuprofen or it could be a long-acting Mobic. But then, can you do it? Yes. But first of all, you have to check, make sure that her renal function is okay. Make sure that they're not on an anticoagulant, because you don't want to start an NSAID and then give the patient another problem. Then the other thing will be, if it's on call, you can always look at it. If it's on a weekend, you can always do something for 72 hours.
Yeah.
But if you start an NSAID because you're sure that the renal function is okay because you have labs, then think about starting a PPI or at least Pepsi just to have the protection.
Yeah.
And I wouldn't do more than 72 hours because then your provider is supposed to come back on Monday, and then we can take it from there.
Yeah.
There's a lot of 90-something-year-old patients, so I wouldn't do an NSAID on them, and probably I'll just start with my Tylenol.
Yeah.
But there's some people that is musculoskeletal that we are not using an NSAID that could be an option for that patient. But as long as you think about renal function, any history, GERD, and if not, if they're on anticoagulant, if they're on aspirin, because 72 hours in a frail person could potentially not cause an ulcer, but cause some type of distress.
I think that's a good point that I sometimes overlook. Yeah.
I know. So that will be.
So how about your next approach? Because I think generally in this population and our acute care providers get really nervous when like we've tried the Tylenol, and my big approach is like make sure we're like doing some of the adjunctive things too. So like warm compress, maybe they just need to get out of bed and walk around because they've been in bed all day. There's like different, making sure we're doing some of those simple stuff. But what if we've done all of those things? The patient is not unfamiliar with like getting additional medications. Where do you see scenarios that are appropriate to say, hey, maybe we'd do a small dose like oxycodone or reaching to help for some of those pain control?
I think for some reason, we use a lot of tramadol. I don't have anything against tramadol, but to me, tramadol is just maybe a little bit more than Tylenol. Having said that, you have this specific 90-something-year-old, super frail and skinny lady that it works for them. So have it there in the back of your mind, but I wouldn't go for it. The other thing is remember that it lowers the threshold of seizures, and we never think about that. So it's there. Will I use it on call? Probably not. I think that if you have somebody that needs a narcotic, I always go, I'll go to hydrocodone.
Yeah.
You start always there. It's not as strong as oxycodone, but most of our patients, they're going to tolerate it.
Yeah.
And like I said, always put a stop date of your orders. If it's during the week, you could do 48 hours. If it's on the weekend, 72 hours to give us time to come. I will never do an order like that for an open ended. And you don't know how the patient is going to react. They might be too sleepy. And you probably might have done Norco 5, 325, might have been too much. They need half of a pill. So as long as I feel comfortable putting orders like that, as long as it's not more than 72 hours.
Yeah. Now, I think that's a good point too, especially for talking about like Tylenol, like a PRN, you're putting stop dates on those. Because
if not, they'll be on it forever.
These patients like polypharmacy are on it for years. And then you're like, why are they taking it? And they're like, well, we just didn't put a stop date on it. So I think that's really important.
Yeah.
Is there any other, sometimes I get questions about a muscle relaxant or like, why don't we use Flexeril in this space? It's like, they feel less scared about like using Flexeril versus, but I'm always concerned in terms of like their central acting, like Beer's criteria, mental status, but like it seems less harmful than maybe a hydrocodone or an oxycodone. What's your takes on some of those?
I think it's totally completely different medicines. If you're really worried about muscle spasm kind of pain, and I guess to get to that conclusion, you will have to have your nurse that's with you. Yeah. Like my nurses call it doctor in the box. So the doctor in the box has to really ask the nurse to feel the muscles and see if it's that. I think your typical, very old and frail, 80 plus, probably is not going to be able to tolerate a Flexeril or a Robaxin.
Yeah.
But I mean, as long as maybe you write another twice a day PRN for pain and you put a 48 or 72 hour stop, there's nothing wrong with it.
Yeah.
But I will be very careful. 90 plus, I wouldn't do it. Unless it's somebody that have been on it before and they're asking you for it.
Yeah.
Because some of these patients come from home that they're already on Oxy, on Flexeril, all kinds of medicines. So if it's somebody that is not naive, I think I will feel more comfortable trying it with a stop date and maybe not going more than twice a day. But if it's brand new person and it's naive, I don't know. Yeah, I'm not sure about that.
Gotcha.
Both medicines have their side effects,
and
I guess.
Kind of why it's hard.
Yeah.
This is a little bit of a hard topic, but and then kind of wrapping it up here, we often get patients who are familiar with the system, maybe I'll say, and we get the threat of, you're not controlling my pain, I want to go back to the hospital.
Right.
So there's that one hand, but like on the other hand, what are some of the things that would cause you to kind of pull that trigger and send a patient to the hospital for pain? What are some of those pain-specific things that would be a red flag to you that you would like, hey, maybe I should send them out for better pain control or evaluation?
I know. I'm a stickler of that because if I know that the patient is just trying to manipulate, I'm going to be like, I don't want to do that.
Yeah.
But having said that, I mean, I think that when I used to be on call, I will agree to like a 48-hour order of an extra pain pill for a 24-hour period to try to appease the person. I think if it's post-surgical and then they tell you, they fell yesterday, then my trigger to say, well, they have to go. To the ER. Maybe another example will be a patient that has dislocation of the hip and they tell you, the hip was dislocated, it was manipulated in the ER, and he comes back to you and they're having the pain again and you're like, well, maybe they have to be seen. Because then the portable x-rays in the nursing home, they're good, but sometimes, they're not. So I will not feel comfortable having a patient post-surgical that is having more pain and then the nurse says, oh, they're on Oxy, now they want morphine. And I'm like, no, I'm not gonna do that. If anything, I will allow you one extra dose of pain pill in a 24-hour period and try that. And let's be very aggressive on ice. Let's, therapy maybe overdid it. But no, I don't think that I will be writing, okay, you were on Oxy, you're having more pain. No, let's give you morphine. And I'm going to say that. No. And actually, Oxy is supposed to be stronger than morphine. So, but
longer lasting.
I know. So anyway, that's that. I think that if he's a post-surgical person, I might send them to the ER because something doesn't sound right. And the same thing with the frail person that has been in the nursing home forever. Well, they may do have a fracture. And that's why they're having more pain. So it's kind of trying to think, why are they hurting? Why is it worse now? What happened? So
no, I think that's an important takeaway is where does the pain come from? Why is there an increase of pain? What's wrong with our approach? We need to have maybe a different approach, but it's hard. It's a hard topic. So, but important because we want our patients to be comfortable and not in pain, but not make our prescribing of medications, their situation worse. So
and we're always going to come back. So whatever you do, just put a stop date. Don't do something that you're not comfortable with. And then, go from there.
So I have a fun part of my podcast that I like to do.
Oh my goodness.
So the name of our podcast is Sniff This.
Sniff This.
So I have some things I want you to sniff.
Oh, goodness.
And tell me if you know what they are.
Okay.
All are medical related.
All are medical related.
So
it wouldn't be gross because if not.
No, I'm not. Nothing gross. You wouldn't forgive me if it was.
Smells like a Bengay kind of thing. Smells like Bengay, menthol latham or whatever you call that thing in English. No? What is it?
This, oh my gosh, it like crowd help. Oh, Pepto-Bismol.
Oh my goodness. No, I failed that one. Totally.
Oh man.
Oh
You,
my goodness.
Big day, like when I was
I
like,
don't know.
oh man, I forgot what this is
Yeah,
too.
uh-huh.
That's funny. There we go.
Okay, let's see. Oh goodness. Now everything is smelling the same.
It's like the micro lab where you have to waft it.
I know, I need a coffee. I'm gonna go with the same thing, the mentholatum thing. I don't
It's
know.
like a vapor rub.
Oh yeah, Vicks Vapor Rub.
There you go.
Yeah, we Puerto Ricans like that one. Why did I forget? Cough syrup? No,
Close.
it's like sweet.
NyQuil.
No. Okay. I don't like medicines. I don't take medicines, man. Let's see.
good.
What's this?
One last one.
Well, he's listening.
I know.
Oh. That's sweet too. I don't know what this is.
Kids.
Kids?
But sometimes we give it to elderly. Just get an oral.
Maalox? No,
You
you don't
talked
give.
about it a lot today.
I talked about it. Tylenol.
There you go.
Ah, one.
You got it good. Perfect.
Yeah.
Thank you. Thanks for being on the podcast today. Thanks for helping educating our providers and improving the care and post-acute care, which is what we're all trying to do. So
You're welcome.
we'll have you on again sometime.
Yay.
All right, my friend. Thank
Okay.
you. We'll see you.
Before we conclude, huge thanks to our sponsor, VitalCare Connect. Whether you're burning the midnight oil or just trying to survive another 2 a.m. call, VitalCare Connect provides on-call medical director support whenever you need it, nights, weekends, and holidays. With coverage nationwide, they're leading the way in post-acute care, elevating quality, expanding access, and supporting well-being for all. Learn more at vitalcare.org. Thank you for joining us for this episode of SNF This. Share this show with your favorite CNA or anyone who's survived an all-staff meeting fueled by cold coffee. Until next time, I'm Chance. In skilled nursing, if you sniff something, say something.